Our next presenter is Dr. Michael Schwartz. He is a professor of medicine here at the University of Washington School of Medicine. He works in the division of metabolism, endocrinology, and nutrition. He is director of a center of excellence, which he will describe. It is on diabetes and obesity. He also works at Harborview with Hugh and I, and he's head of clinical nutrition. He obtained his medical degree at Rush Medical School. He then moved to Seattle, and he completed his residency in internal medicine here. This was followed by a fellowship in the division of metabolism, endocrinology, and nutrition. Now, his work is at a cellular level, and he has studied both inherited and acquired impairment of neurons. And so he's going to be talking about the brain, and he's going to be talking about how obesity and diabetes are related. And he wanted me to point out that this is not his stomach in this photograph. He has amazing scientific talent and is a wonderful investigator. He's received numerous awards. A few are listed here, from Columbia University, the Outstanding Achievement in Diabetes Research. He's received, at a very young age, the Young Investigator Award from a national group called the American Federation for Medical Research, and also the Young Faculty Award from the Western Society for Clinical Investigation. He's going to discuss fat cells, and he's going to show us pictures of obese mice, and he also promises to explain to me why I'm so hungry right now. So thank you, Dr. Schwartz, for joining us.
Well, thank you very much for that very generous introduction and the opportunity to address this group, who obviously is very interested in this topic. If you want to start at the beginning and you say, well, you know, what is the basic core of information you want to know about? For me, you could start with the question, what exactly is body fat? And you have to realize that it's not just fat accumulating in your body, but it's actually a highly sophisticated, evolutionarily developed way for the body to store fuel. Since we're not walking around eating all the time, we have to have fuel stores available to meet our energy needs when we don't have food in our stomach. And so millions of years of evolution have gone into this, and the fat, which what we're really talking about is triglyceride, which is a very common type of fat, accumulates in specialized cells in the body that are known as adipocytes. And when you need the energy, the fat in the adipocytes is broken down and released into the circulation, where virtually all of the tissues in the body can use these components of triglyceride to meet energy needs. And this is just a depiction of what a fat cell looks like. There's the cytoplasm is all pressed against the side, and here's the nucleus, and then there's this big fat droplet in the middle of it. This is a micrograph. This is an electron micrograph showing what these adipocytes look like, and this is a section, stained section, and this is the fat droplet here, and here's the cytoplasm pressed up against the side. Now, you might imagine that as you become heavier in obesity, the fat cells get bigger, and that's essentially what happens. You're just storing more fat in the fat cells. You can also get an increase in the number of fat cells, so both things happen. A couple more interesting facts about body fat. It turns out that body fat is actually an endocrine organ. It secretes hormones into the body that affect a variety of different parameters, and one of them is your body weight. And one of the key hormones I'm going to come back to is called leptin, which is in fact secreted into the bloodstream from fat cells. One last point is that the disease risk associated with obesity is strongly influenced by where body fat is stored in the body. And in particular, if you store fat within the abdomen, that's the worst place to put it in terms of metabolic and cardiovascular risk. So let's say a couple of words about intra-abdominal fat and metabolic disease. And we've heard about the relationship between obesity and diabetes, and this is just another way to look at that. This is a kind of a complicated graph taken from a paper that was published more than 10 years ago. This is not my own work. But what we're looking at is the risk of type 2 diabetes in the y-axis here, the BMI quintiles. So this is just the body mass index, and these are lean people here, normal weight people here, and obese people here. This over here is the waist to hip ratio. So this is a measure of how much fat is in the waist area or the abdomen compared to other places of your body. And so the point is that if you're in this fifth quintile here, this would be people that have a lot of intra-abdominal fat, whereas the people down here have very little intra-abdominal fat. And the point I would make is that it's true that as you increase your BMI, the risk of diabetes goes up, but the effect is much more dramatic for people that have intra-abdominal fat, which is what's shown here in the blue bars. So really, at any BMI, the risk of having type 2 diabetes is much greater if you have fat preferentially stored in the intra-abdominal compartment. So what we're really talking about here is something known as the metabolic syndrome, which is a complex of symptoms or disease manifestations that tend to go together. And the key to all of this is this central intra-abdominal fat. And when you have that, it predisposes to impaired glucose metabolism and diabetes for reasons I'm going to talk about in a moment. It also is associated with impaired lipid metabolism. So I'm talking about your plasma cholesterol level and your plasma triglyceride level. It also impairs the control of blood pressure, so it increases the risk of high blood pressure or hypertension. And all of these things together increase the risk of coronary artery disease and premature death. So how are diabetes and obesity related to one another? And I'm going to try and boil this down to something that's probably an oversimplification, but it gives you a useful way to think about it. One thing that is clear is that obesity causes something that we call insulin resistance, which is a condition in which the ability of insulin to lower blood sugar, which is one of the major functions of insulin in the body, is to lower the glucose level in the blood by driving the glucose into tissues where they'll be used or stored. Well, if you're insulin resistant, then the normal amount of insulin is not going to do a very good job of clearing the sugar from the bloodstream. So you need to make more insulin in order to meet the challenge posed by insulin resistance. Now, the people that have type 2 diabetes are people who have insulin resistance, but they also have a genetic predisposition to an impaired ability to secrete insulin. And so they are the people, when you need to make more insulin, they can't do it. And it tends to be a progressive disorder over time, so that the impairment of insulin secretion gets worse and worse to the point where the blood sugar actually rises out of the normal range. And so this is really what causes type 2 diabetes, and we don't really know exactly what causes insulin resistance, and we also don't know exactly what causes the impairment of insulin secretion. These turn out to be very complex issues that have multiple genetic components and on which these environmental factors are superimposed. So the result is type 2 diabetes, and as you know, it is increasing in prevalence not only in the US but worldwide. Up to 20% of the adult population in this country over 60 years old has type 2 diabetes now. The cost in the US was estimated to be over $130 billion a year, and it's becoming a huge global health concern. So it's one of the major complications of obesity that adds to the healthcare burden not only in the US but worldwide. And I'm not just talking about developed countries like Western Europe, but India, China, huge problem with type 2 diabetes. So let's shift gears a little bit and talk about what causes obesity in the first place. Now, by definition, obesity is an increase of stored fat or stored energy, basically. So in order to have an increase, you have to consume more calories than you're expending. In other words, you're in positive energy balance. So when I first learned this many years ago, I thought this is pretty boring. You know, why would you want to spend your career studying a situation where people are eating more than they're expending? It seems like you already know what the cause of obesity is. But it turns out that it's a little more complicated than just that. And one of the key questions that I'd ask you to think about is obesity really just due to a lack of willpower, or is there something else going on that is important to understand in the control of body weight? Let me give you a specific case that highlights the point that I want to make. This is a true set of data from an individual that was studied by my colleague John Brunzell here at the University of Washington some years ago. This study volunteer came into a clinical research environment where the food that he was given was controlled by the scientists and not by him. And he signed up to participate in the study, and one of the endpoints of the study had to do with seeing what happens when you lose weight. So this guy came in weighing 120 kilograms, which is over 250 pounds. So he was obese, and he went on this very low-calorie diet of 600 calories per day. And you can see that over 3 months, he lost 40 kilos. So he lost 1/3 of his body weight. And then at this point, his diet was changed so that he was given the amount of food to eat that was estimated to meet his energy requirements in this reduced body weight condition. So now he was able to maintain this low body weight. And so if the question is, can you eat less and lose weight, and then can you maintain the weight loss, the answer is actually yes, you can do it, as long as you're not making decisions about how much you're going to eat. Okay? If somebody else is making the decisions, yes. So at the end of the study, this gentleman left the research center, he went back home, but he had to report back in periodically to follow up on how he was doing. And so what do you think happened when he left the research center? Well, he rapidly regained all of the weight that he had lost. And this is impressive to me, not only because of the rate at which he regained 40 kilos in a month. That's more than a kilo per day. So you can gain a lot of weight if you're motivated. But the point here is that not only did the weight accumulate rapidly, but notice that he didn't come back and stabilize at a level that was below where he started, and he didn't stabilize at a level above where he started. He stabilized right where he had been before. And this suggests that maybe in this individual, this body weight here is what was being biologically defended. And when you try to perturb that, you activate compensatory responses that bring you back to this weight. The cumulative data would fit with this notion, because if you look across, this was done a number of years ago, but at the time it was a compendium of all of the 16 studies that had 5 years at least of long-term follow-up on individuals who had lost weight through calorically restricted diets. And what we're looking at is the percent of the lost weight that is regained over time on the average of these 16 studies. And the point is that if you wait 5 years, 90% or more of all the pounds that were lost will have been regained. And this is, again, not by accident or chance. This is a biological response to voluntary efforts to achieve weight loss. So this brings us to a term that we refer to as energy homeostasis, and it can be defined as the physiological process whereby energy intake, or food consumed, is matched to energy expenditure over time to promote stability in the amount of fuel stored in the form of fat. Now, from an evolutionary point of view, it would be reasonable to ask, why would we have evolved a system that would maintain stability in body fat stores? And I thought Bruce Spiegelman had a good answer to this. He said that certainly the ability to store energy is a highly valuable trait in animals that have intermittent and uncertain access to food. So you need to have some stored energy. However, excessive adiposity would be expected to make an individual both slow and highly palatable, a very bad combination for survival. So the point is there was evolutionary pressure to limit weight gain and prevent you from becoming too obese, in the same way that there was evolutionary pressure to make sure you had enough fat to be able to survive. So let's get back to this question that I've been circling around here for a while. Why, if you lose weight, what drives the weight to come back? And in order to make the point here, I'm going to show you some data in rats. Again, this is not my own data. This is data that was published more than 20 years ago, but it makes the point nicely. And this is a very simple experiment. This is the body weight in the upper panel of two groups in rats and their food consumption on a daily basis on the lower panel. And the group shown in the broken white line here is the control group that is allowed to eat as much as it wants to, and it maintains a stable or gradually increasing weight that you see here. And in the yellow line is a group of rats that is subjected to a period of fasting shown in this green bar here. So when the food is taken away, not surprisingly, the group that is subjected to food restriction or food deprivation loses weight. Okay, no surprise there. Now, what happened after that food restriction was lifted is really just what I showed you in the human, that the lost body weight comes back. It comes back exactly to the control level of the rats that were never food deprived. So this suggests there's some regulation going on. Well, how did this occur? If you look at the food intake data, you get a sense of what's happening. And the point here is that the food intake peaks early on within the first day, and then as body weight is being gained, the food intake increase begins to drop off. So that the closer the animal is to the control body weight, the less of an increase of food intake there is. And at the end of the experiment, at the time that body weight is returned to normal, food intake has also returned exactly to normal. So what do we deduce from this? Food deprivation increases the drive to eat such that consumption of food is high once the food is returned. This increase in the drive to eat decreases as the amount of body energy stored in the form of fat returns to normal. If you combine those observations with a couple of other observations, a bigger picture emerges. First of all, even among people who become obese, body weight tends to remain relatively stable over long time intervals. And I would imagine there are many of you in the audience today whose body weight really hasn't changed at all over a period of 5 years or even 10 years. Well, if you think about that for a minute, what did your body have to do in order to maintain stable weight over 10 years? A normal man who weighs about 150 pounds will consume about 1 million calories per year. Now, if that individual expended only 99.5% of those 1 million calories, he would gain about 2 pounds of fat. So even if you're 99.5% accurate, but you're consuming just a little bit too much, it translates into increased fat. And if you did that every year for 10 years, that's 20 pounds. So even if you're 99.5% accurate in matching intake with expenditure, if you're off by that 0.5% every year for 10 years, you gain 20 pounds. And of course, gaining 20 pounds over 10 years is very common in our society. So my argument would be that people who gain that type of weight are doing it despite the fact that their body weight regulatory system is actually working very well. It's just not working perfectly. So the hypothesis then for how body weight regulation occurs, what are the systems that are actually achieving this? The hypothesis is that our bodies make a substance that suppresses appetite, but that the amount made decreases when fat stores are reduced by energy restriction. And this is a diagrammatic depiction of what I just said. This is the so-called negative feedback model for control of body fat content. And it provides the basis for understanding how energy homeostasis works. So what we're regulating is body fat stores, and one of the controls that regulates body fat is how much food you eat. And of course, how much food you eat at some point is really driven by the control of appetite in the brain. And the hypothesis is that the way that fat stores are linked to appetite is that there is a circulating signal or set of signals that are generated in proportion to body fat that act in the brain to inhibit the brain circuits that control appetite. So when this signal is high, you eat less, and when this signal is low, you would eat more. So in other words, if you go on a diet and lose weight, the fat stores drop, this inhibitory signal drops, this releases the control of appetite from its inhibition that it was receiving from this circulating signal and allows you to eat more until you've recovered the lost weight. Well, about 14 years ago, there was a discovery made in New York that had to do with this hormone known as leptin. Basically, the gene encoding leptin was discovered by Jeffrey Friedman and colleagues, and it rapidly found its way into our understanding of energy homeostasis because it became clear immediately that it met several criteria for this missing link of a humoral signal involved in this control system. First, it's released into the bloodstream from the body fat cells themselves, and it circulates at levels that are proportionate to body fat mass, which is exactly what you would predict for a signal involved in energy homeostasis. Secondly, it acts in the brain to reduce appetite. So if you take an experimental animal like a rat and you inject leptin directly into the brain, they will reduce their food intake dramatically for a couple of days. But what I really like about this model is that it allows you to test very critical and important questions. And one of them is, what happens if leptin is not made? Because what you would predict is if this hypothesis is correct, and if the brain is counting on leptin to inform it about how much body fat mass there is, that if you don't make leptin for some reason, for example, if you have a mutation in the gene encoding leptin, so you have leptin deficiency, then the brain would get the message that there's no body fat stores no matter how much fat you have. So the brain would be driven to increase food intake even though you're already fat. So you'd end up with a fat animal that is eating too much food even though it's fat. And that is exactly what happens in this animal. This is known as the OB mouse, and it has a mutation in the gene encoding leptin, so it makes no leptin. This is its lean litter mate. So this is a normal mouse, same litter, same age. This is the animal that lacks leptin. And this animal will eat 50 to 75% more food every day than this animal. And we know that it's due to leptin deficiency because if we give this animal leptin back, it becomes essentially normal. So you could say, well, that's great if you're a mouse, but what does this have to do with humans? And it turns out that leptin is very important in humans because although leptin deficiency is rare, in every case that has been documented of genetic leptin deficiency, severe obesity results. And moreover, in those few individuals, and there's now about 10 or 12 individuals who have been documented by a group in England led by Stephen O'Reilly, who have genetic leptin deficiency and have severe obesity and are being treated with leptin, they essentially become normal body weight as a result of this simple intervention, which all came about because of a hypothesis and a set of studies that were done originally in mice. So how does leptin work? And this is work that my lab and others here at the University of Washington have been involved in for many years. And I'm not going to get too complicated about this. Really, the way that we approached it is that there's three possibilities for how leptin could work. it either inhibits neurons that stimulate food intake, and that would reduce food intake, or it stimulates neurons that reduce food intake, and that would also reduce food intake, or it could do both. And so what is the answer? Well, of the three possibilities, it turns out that the answer is that leptin does both of these things. So let me orient you a little bit to what I'm talking about. Now, this is a rodent brain, a schematic illustration. The nose would be out here, and this is the hypothalamus. So if we take a section and now we look at it face on or in the coronal plane, now we're looking at this. So now this is the hypothalamus, this is the cerebral cortex, and this area here is called the third cerebral ventricle. It's just a reference point for us. And the area shown in blue is called the arcuate nucleus. And it's an area that I'm going to focus on for a moment because this is where the action is as far as leptin is concerned, or at least it was the first area to be described to house neurons that are important in leptin action. And so let's take a close-up now. We're going to do a magnified view here with a histochemical image of these neurons. And this was work done in collaboration with Dennis Baskin, who works here at the VA Medical Center in Seattle. So now we can see this third ventricle. This is the floor of the hypothalamus. This is an area known as the median eminence. And this whole area here is the arcuate nucleus. And what we're seeing are the two sets of neurons, one in green and one in red. The neurons in green contain a gene that expresses a gene that encodes a peptide known as neuropeptide Y, or NPY. NPY is a very powerful stimulator of appetite. The red neurons contain pro-opiomelanocortin, which is the precursor for melanocortin peptides that reduce food intake. So that's just summarized here. NPY stimulates food intake, melanocortins reduce food intake. So what does this have to do with body weight control? Well, it has to do with the connection to leptin, and then leptin is the connection to body fat. So remember, leptin is being made in proportion to body fat. And leptin acts on these two neurons in a very robust way, but in an opposite way. So the NPY neurons stimulate food intake and are inhibited by leptin. The melanocortin neurons reduce food intake and are stimulated by leptin. So the way to think about the melanocortin and the NPY neurons with respect to the control of food intake is kind of like what you do when you're driving a car. If you want to go faster, if you want to go forward, you step on the accelerator pedal while you take your foot off the brake. In other words, there's two different control mechanisms, one that pushes you forward, the other that slows you down. It's the same here. The NPY neuron is like the accelerator pedal for appetite, and the melanocortins are like the brake pedal. So if I put an injection of leptin into your body, that will inhibit the NPY neurons. It's like taking your foot off the brake pedal while stimulating the melanocortin neurons. It's like taking your foot off the accelerator pedal and stepping on the brake pedal at the same time. Now, on the other hand, if leptin levels are low, then you get the opposite effect. It's like you're stepping on the accelerator pedal for appetite while you're taking your foot off the brake pedal. And so when would leptin levels be low? Well, leptin levels would be low when you've lost weight, because if you've lost weight on a diet or for some other reason, your fat stores are shrinking, the leptin levels are going to drop. And these responses in the hypothalamus of the brain are very important for understanding how you end up eating more to recover the lost weight. There are other hormones that I'm not going to focus on that are also involved in this, but I just wanted you to understand that leptin is not the only signal. And these same neurons are also reading input from glucose and fatty acids and amino acids. So what does all of this have to do with obesity? Well, first of all, most obese individuals are in fact resistant to leptin. They have high levels of leptin, but it's not suppressing their appetite. And in fact, if you give leptin injections to obese people, they tend to not respond very well. So just in the same way that obese people are insulin resistant, they're also leptin resistant. Another point to keep in mind is that obesity is not simply the passive accumulation of excess body fat, but it's a re-regulation of body weight in an upward direction. So at any one body weight, even as you're gaining the weight, that level of weight that you have is the one that you're going to defend. Now, the mechanisms driving this response have to do with an interaction between genetic and environmental factors, but I'm just going to try to show you schematically what I'm talking about. This is not real data. This is an illustration of a bell-shaped curve that shows the distribution or the frequency of body fat content in a population of individuals. So the people with the average body fat content occur most frequently, and the individuals with low body fat content would be out here, and with high body fat content would be out here. Now, the point is that individuals with low body fat are those that tend to have some genetic protection against obesity, and they tend to live a healthier lifestyle, or some combination of those two factors. Individuals who tend to become obese have genetic susceptibility to obesity, and or they have some sort of unhealthy lifestyle along the lines that we heard about earlier. So, what is driving recent increases in the prevalence of obesity? The genes and the basic biology are not changing, but the environment is. And I would say that, as we heard about the fast food, the increased meal size, the decreased physical activity during free time or during school, the increased consumption of high fructose corn syrup containing beverages, the decreased physical activity in the workplace, and all of these things, and many others that you could imagine, are pushing this curve in this direction of increased body fat. So you're basically taking the same genetic predisposition and changing the environment in ways that favor weight gain. So what are the implications? Well, you can target leptin resistance through a drug approach, and that's being looked at. Or you could target neurocircuits downstream of leptin in the brain, the same ones that I talked about. There are a number of other mediators that could be important targets that I won't go into in any detail. And one point I wanted to make about bariatric surgery, especially the gastric bypass, is that the key to success is not really primarily that it limits mechanically how much food can be consumed, but that individuals who lose weight don't seem to mount the adaptive responses that drive body weight back up the way that would occur if you just were on a calorically restricted diet. So it's as if there's a re-regulation of body weight at a lower level. But I do want to point out that even modest weight loss can have beneficial effects in individuals that are at high risk. This is data from the Diabetes Prevention Program published several years ago, in which individuals who were obese and known to be at high risk of developing type 2 diabetes were put on one of 3 different treatment interventions over a period of 4 years. One was just a placebo control. One was a drug treatment with a drug called metformin. And the third was a lifestyle intervention that consisted of a healthy diet and increased physical activity that resulted initially in a loss of weight of about 7 kilos and then gradually increasing weight to only about 5 kilos or about 10 pounds by the end of the study. And this just shows that the lifestyle group was much more active by design than the other groups. The important point, though, was that if you looked at the cumulative occurrence or incidence of type 2 diabetes, the individuals in the placebo group, about 35 to 40% of them developed diabetes within 4 years, whereas about half or less in the lifestyle group developed diabetes over the same period of time. So even a modest but significant weight loss associated with lifestyle intervention can have important protection against metabolic disease. And the last point I would make is that, in my view, the most important strategy is to promote obesity prevention through dietary and lifestyle intervention, because once you have established obesity, it's much harder to achieve and maintain weight loss And I think there's a lot more potential benefit in trying to prevent the weight gain from occurring in the first place. I just want to close by letting you know about something new that's happening in Seattle related to the University of Washington. This is a satellite view of Seattle. This is the south area of Lake Union. And this area here is where there's a new biomedical research campus for the University of Washington that's going in at South Lake Union. And one of the research groups that will be going into this building is the group called the Diabetes and Obesity Center of Excellence. It has a number of faculty moving in there and areas of research that include obesity and energy balance, diabetes, atherosclerosis, and lipid metabolism. So I just thought you might be interested to know where the university is going in this area. And thank you very much for your attention.
Great job. Let's have a seat.
I just wanted to know how the body decides where to store fat. I hear all the time about the dangers of the abdominal fat, but what's going on in the body to decide where to gain weight and where to lose weight?
That's a very good question, a very important question, and one that we know surprisingly little about. So the short answer to your question is there is no widely accepted biological understanding for why one individual might gain weight in a more healthy distribution, say around the hips and legs, whereas another one might gain it centrally. But having said that, sex hormones probably have a role, because healthy young women who become obese tend not to have so much of a central obesity problem, whereas men do tend to have a higher risk of having the central obesity problem. But then after the menopause, the women start to look much more like the men. As they become obese, they have similar rates of central obesity. So probably female sex hormones have a protective effect on intra-abdominal fat and on obesity in general, but the exact mechanism that would explain that has not really been provided yet.
Actually, I work in obesity research at the university and Children's Hospital, and I'm wondering if I could hear a little bit more about, there was mention about the Farm Bill and how you see the necessity to reformulate that such that it, changes the disparity. And like right now, we see like corn is highly subsidized, and so high fructose corn syrup is something that's very low priced but very bad for us, whereas more healthy things are much more expensive. The research I do looks at environmental factors in physical activity and in food, and I see solutions as far as government funding parks and things like that, and encourage people to be more active. But I don't really see solutions as readily available for changing people's consumption and relating that to poverty and SES.
Yes. Well, the issue of food prices and subsidies has been dealt with much more eloquently than I could ever do it by Michael Pollan, who actually was here a few weeks ago to give a talk at the town hall. So I actually recommend you read his book, The Omnivore's Dilemma, where he does quote my research on food prices and diet costs. Again, having said that, I think that we're now entering a new stage of global nutrition transition, and we will be wishing for the good old days when we had unlimited high fructose corn syrup and added sugar and added fat. What has been happening is that a lot of agricultural production is being diverted towards biofuels, notably ethanol, and food prices are rising worldwide. So formerly we were thinking that the obesity epidemic was riding on this global wave of cheap sugar and cheap fat, and as I say, these may turn out to have been the good old days because prices are doubling and tripling. So now what? I was giving a talk on this topic, and someone from public health, I regret to say, stood up and said, "That's very good news for public health because people will lose weight." I said, absolutely not. We're going to look forward to political instability and social unrest. So dramatic days are coming and are in front of us. So yes, we need to have change in government policy, but right now it's very difficult to know what those policies should be And it's not just the national farm bill. This is really a question of global international policy. And I know that the Food and Agriculture Organization of the United Nations and the World Bank are looking at this issue, but what's going to happen, I have no idea.
Yes, I have a question for Dr. Schwartz, and this involves the time constants for the leptin to restore the natural level of body mass index. For example, suppose one goes on a binge typically at between Thanksgiving and beyond, December, January, and puts on 5 pounds. Let's take the case of a 550-pound person, for example. So how long does one have to get that extra 5 pounds off before the body adapts a new level?
Well, that's a good and interesting question, and there's probably not a simple answer to it because there's going to be some individual variability. In other words, another way to think about it is what happens when women are pregnant. And the natural response to pregnancy is to gain weight, including body fat mass. And somewhere around 60% of women who have their first pregnancy will lose all of the extra weight that they gained as a result. But somewhere around 35 or 40% won't. And they never seem to lose that weight. So it's as if the cost of the weight gain associated with the pregnancy for them was that now they're stuck with regulating a higher level of body weight. But in terms of the leptin response, really the job of leptin and this whole energy homeostasis system is to correct over long time intervals the short-term mismatches which are inevitable every day. I mean, obviously we're not matching energy expenditure and energy intake to within 0.5% every day. There can be huge mismatch. And the whole point of the system is to detect the mismatch when it occurs in a sustained way and then activate compensatory responses that get you to come back. And that will occur over a period of days or even weeks. And so it's a relatively long process.
As a male, I take it that that's at least gives me a month or two.
If one posits that obesity is related to socioeconomic status and that the incidence of complication for surgical treatment of obesity have fallen significantly, and David, you're a guy who runs you're both kind of numbers guys. You both use epidemiologic data to conduct much of your research. Maybe we should do some calculations to see what the benefit would be in terms of total less expenditure if we were to fund surgical treatment of obese poor people, because it's difficult in many states, in most states, and to get a surgical procedure if you have no commercial health insurance.
So right now there are about 12 million people in the United States who are eligible for bariatric surgery by the weight criteria. So as a public health response, can you imagine even if a third of those met those socioeconomic status criteria, that it would be an overwhelming number of people that we'd be treating. And it doesn't seem like it's the right thing to do, frankly, to think of that as the only option. Turns out that many states are taking the most extreme cases, and in Washington State, for example, the Medicaid program, which covers the people in the social safety net, if you will cover bariatric surgery only for two groups: patients who are extremely obese with a body mass index, it's very extreme, and diabetics, because of the potential savings and costs for treating a diabetic and putting that patient into remission. It's a very provocative question without a great answer, right? And I think the challenges lie ahead for sure.
Great. Well, we want to thank you all for staying. Thank our speakers and panelists.